with this chapter, I did cut out the beginning that went over some anomalies. It also went over STDs, which you guys learned from microbiology, so we don't have to revisit that. So I'm going to talk about some congenital disorders, and then we're also going to go into certain cancers, okay? And that's that. Now with reproductive, let me just say this. This information is not that heavy, okay? So what I need you to know, basic stuff with this information, I need you to know pretty much the title of what the disease is and the description of the disease. We will go over some signs and symptoms and some treatment, but it's not heavy, heavy material. It's not heavy, deep physiology that's involved with it. It's just basic anomalies. Maybe is this one, say for example, hindered testes has not descended. Okay, so nothing special with the whole physiology of that. Okay. Now, the first thing we're going to go over is cryptorchidism, which is what is called hidden testes. Okay, so the testes fail to descend. Now, as you know from embryology, and I'm not sure if you went over this in anatomy, I don't know if you've heard the saying that boys and embryos start out looking like girls, okay? And it's true because what happens, all of the reproductive organs start a little higher up and then they do descend. Now the testes in embryology in the male will start to develop in the abdominal cavity, okay? And then they fall down into the pelvic cavity as development occurs, okay? Now with this situation, what happens as development goes on, the testes do not descend. Okay, and so what happens, they stay higher up in that area. Now, if they stay higher up in that area, as you can imagine, this will pose a whole bunch of problems, okay? So, they do give here the positions, which I'll show you in a second. What else here? Failure to treat causes fibrotic tubules with deficiency in spermatogenesis and infertility. So, obviously, if the testes stay in the abdominal cavity, what will happen is this will definitely pose an issue with making sperm production. It will also pose an issue with how sperm flows, okay? So this will now lead into a whole host of infertility problems. Okay, and they say increase of malignancy if this goes untreated. Okay. Oh. Okay, so they're showing you different areas where the testes can actually stay, okay? So here, as we talked about in embryology, this is the highest, as you can see, where it starts out in the abdominal cavity. Then these different areas here, you have suprapubic, superficial inguinal, okay? High scrotal area. It can go over down to the femoral region. Okay, so everywhere else, okay, except for its normal position, okay? So those are the different positions. Not so much this chapter, but just to give you a heads up, next chapter for female reproductive disorders, I will have pictures, okay, that I will put on the test, all right? But this one, I don't think I have pictures for this.
Wait.
Yes. For female. I won't use pictures for male. There's not any male disorders that I'll put pictures of.
But you're going to upload those pictures for us, right?
Yes. And I'll let you know, and those pictures are actually in your book too, but I'll let you know which pictures. Okay. But for this slide, let me say this. I do want you to know the different regions that the testes can fall under, okay, or be hidden, okay, where the testes are hidden. So I would say please make sure you know the areas where the testes are hidden. So even if I don't have this actual picture, I could have a case study type question where the patient's testes are in the suprapubic region or whatever. Okay. Now, treatment, orchiopexy, okay, and what that means is this is just for them to surgically remove the hidden testes. Okay, to surgically remove the hidden testes. Or they can give the patient human chorionic gonadotropin in an injection form. And what happens here, when you inject a person with HCG in this situation, it will now therefore increase the development. Okay, so it'll increase the development of the testes to move down to where it's supposed to. So that's cryptorchidism. Now, the next one we're going to go over is something called hydrocele. Okay, hydrocele, testes are in its normal position, but the issue here is that there's fluid around the testes. Okay, so fluid does collect around the testicles, spermatic cord. And what happens here, I do want you to jot this down, that they do notice this in infants and young boys. So this is more noticeable in infants and young boys. Another clinical feature I do want you to jot down with this particular case is that the scrotum is small and soft in the morning, but at night it gets large and filled with fluid. So the scrotum is small and soft in the morning, and at night it gets large and filled with fluid. And just to let you know also, this fluid most of the time comes from the abdominal cavity. Okay, so the fluid from the peritoneum. So the fluid from the abdominal cavity or the peritoneal region can now just kind of leak down into the testes, causing this extra fluid around the testicles. Now, they do give you some other causes that can make this situation happen. Develop secondary to scrotal injury. Yes, as we know with any type of trauma to that region, that can increase inflammation and fluid and so forth around that area. Radiation therapy can do that. Infection and sometimes testicular cancer, okay, can now cause extra fluid to build up in that area. And again, if it is a testicular cancer situation, this fluid buildup comes from that whole immune inflammatory process, okay, where that fluid is just around that region. So, how do they treat this? Very easy, drain it, okay, if necessary. They say sometimes these things do subside depending on how much fluid, okay, or what the actual issue is. But again, drainage will probably be the best thing, okay. So there's a picture there showing you how that fluid just builds up in the scrotal sac and it's just surrounding around the testes, okay. Now, Spermatocele, okay, so much like a hydrocele, this is different where instead of fluid, this is a mass containing sperm. Okay, so sperm will just build up in the scrotal sac. Can be large and difficult to distinguish from a hydrocele. They're not sure what causes this. One thing I do want to say about this with hydrocele and spermatocele, and well, some of the other testicular things that we're going to talk about. Please understand, in order to really see this and visualize this, they didn't put it here, but there is testicular ultrasounds that are done, okay? And it's funny, I remember one of my friends, she was going to school to be an ultrasound tech, and she said, "Did you know I had to ultrasound somebody's testicles?" And so, you know, she was quite upset about that. But this is something that has to be done because this is the only way of diagnosing what is actually inside, okay? So whether it's a spermatocele or fluid or whatever it is, that's the only way you can see what is actually inside the scrotal sac by doing an ultrasound. So treatment here, they say none, okay, hopefully it'll go away, or they can do an incision and take it out. Now, the next one here is something called testicular torsion, okay, testicular torsion. And this was a little more complicated, as you can imagine. And so what happens here, this is a twisting of the spermatic cord, okay? You know where the spermatic cord is located. Spermatic cord gets twisted, and what happens if the spermatic cord gets twisted, what else lies with the spermatic cord that you know from anatomy? Blood vessels, very good. Blood vessels run there, so if that gets twisted, those blood vessels are actually twisted as well, which now cuts off blood supply and can now lead this into an ischemic situation, okay? Please make sure you know that. Now, they do say that this can occur in pre-puberty boys, okay? I would jot that down. This can occur in pre-puberty boys. Okay. This is what it looks like. Okay, so it's not a pretty sight. where you see here the testicles, and then here is the spermatic cord, and it's just all twisted, okay, like a rope, with the blood vessels along with it, okay? So therefore, yes, cutting off that blood supply and getting to the testicle itself. If this is not treated, then we're now talking about ischemia, okay, to that region.
Here's a question.
Yes.
I'm just curious, like, how does this happen? Like, does it happen naturally?
It happens naturally. There's no particular trauma or anything. It just happens where it just twists upon itself. They're not sure exactly what causes it, but it just happens naturally. It's working, maybe working too hard or something, I don't know. Okay, now, clinical manifestations, primarily again in pre-puberty boys. Severe pain in one testes, okay, so that's definitely a clinical sign. Severe pain in one testes, swelling also of the scrotum. So much like if anything's twisted or any type of trauma in that region, yes, there will be swelling. And nausea and vomiting is also accompanied with this. The diagnostic tests that I talked about before, Doppler ultrasound and testicular nuclear scanning. So it is good to have an image, okay, with the Doppler ultrasound to see exactly what's going on, how much twisting is occurring, okay, so that way they'll know exactly how to treat it. Treatment, this is an emergency situation, as you can imagine, again, because we're cutting off blood supply. The treatment here is surgery, okay, as you can imagine. It's not going to untwist itself, yes. So what they do is something called a PEX, where they will actually untwist the testes to the scrotal wall. So they'll untwist it and then put these clamps to hold it down to the scrotal wall. And that way, I think what happens here, they wait, I think 12 hours to see if it doesn't curl back up. And then that's the treatment, okay? And that usually takes care of it. Now, if it curls back up, I don't know what else they do from there. But that whole PEX, or the whole, I should say procedure, is to untwist it, hold it down, okay, to make sure that it stays in its proper position. Okay. So that's that. Epididymitis is inflammation of the testes from trauma. This can also be a reflux of sterile urine up the vas deferens or secondary to a bacterial infection. And when we say bacterial infection here, I do want you to know that we are talking about STDs. So STDs could lead to an epididymitis, okay, meaning that that bacteria can just kind of get up into the epididymis and cause an infection there. Clinical manifestations and treatment: enlarged red tender scrotum, pain with radiation to the inguinal region, and elevated white blood cells and urine positive for the organism. Please understand that most of the time this situation is more from a bacterial infection, okay? And we don't want to say, oh, somebody has epididymitis, it's definitely an STD. No, we're not putting it in that category. But it could be an STD type bacteria or just any other kind of bacteria, maybe just from an influx of urine, maybe a urinary tract infection that has gone a little too far, okay, up the reproductive tract. So this is how this happens. The way they treat this is antibiotics, okay, again, because the main culprit here is the bacteria. Okay, and rest. That's easy. These are so easy. They say we have to go through this because when you guys get into, well, OBPs, and especially when we get into females, female disorders, prolapse and all those things, have to go into that. Because what happens, you don't get this information from your previous courses, so we got to make sure we get it here. Okay, Fournier's gangrene. Okay, just to let you know, if you want to jot this down, they do say that this is caused by some underlying diseases. So this particular situation, Fournier's gangrene, can be caused by diabetes. It could also be caused by alcoholism. Diabetes and alcoholism. And so basically what they are saying here with diabetes and alcoholism is that the diabetes and alcoholism can predispose these individuals to infection, and then they can get the infection in the scrotum. Okay, so that's how it works out. Now, they say this is a severe situation, but rare. Okay, I haven't really heard much of this type of disease. But this is rare because this is a type of gangrenous necrosis to the scrotum. Okay, so that definitely is a severe situation. If the scrotum gets gangrenous, we know that it's not what you can do about that. Now, manifested by pain, swelling, fever, chills, and sepsis, because again, the infection is the cause of this. Make sure you know that. The infection is really the culprit here. Diagnosis is made by history, physical exam, so seeing exactly what is in the patient's past history. Have they had previous infections? Are they a diabetic that's uncontrolled, okay, and not taking their meds and having a host of problems that's going on with them? So these are things that have to be considered. Ultrasound, CT scan, and MRI of that area will show the gangrenous scrotum. Okay, so all of those images will show that. Treatment here is to do an incision and drain. And what happens here is that they can drain this necrotic tissue. Okay, I assume that this is more of a wet gangrene. Remember we went over dry and wet gangrene. And wet gangrene is more for internal organs, if you remember me talking about that. So, and thank God in this situation that they don't have to cut the scrotum out, because you would think that that's what they would have to do with it being gangrenous. But what happens here, because of the type of gangrene, which I assume it's wet, they can drain just that portion. Again, not quite sure how common that is. This is not that common of a disease, but just in case if you see it. Okay, now, the next thing we're going to talk about are some neoplasias of the testes. And with neoplasias of the testes, we will talk about the benign ones and then the malignant ones as well. Okay, so with neoplasias of the testes, they give you here the peak incidence in late adolescence to early adulthood. Most of the times when men do get diagnosed with testicular types of cancer, it's not such of a late age, okay? It is usually an early age, unfortunately. They say early detection is the best, so much like with women that have to do the self-breast examination, men should also do testicular self-examination. And I don't know, I know they usually do a lot of campaigning with teaching females how to do breast exams, self-breast exams, but I don't know how much campaign they teach for testicular cancer, which they should do just as much. And especially if they know there is a family history that's going on. Okay, that's very important. Now, etiology here, they say some causes of testicular cancer is associated with the cryptorchidism that we first talked about. So those hidden testes, so they do know that a percentage of boys that do have the cryptorchidism do have a chance of unfortunately now leading into a testicular cancer, okay, because of the whole situation with that. Histology is also something that has to be looked at, looking at how these cells are actually going into the rate of mitosis, and keep in mind that abnormal cells that may come from the normal, I should say, reproductive cells that they should have. Now, treatment, again, depends on the type, okay? And we'll go over each and every treatment when we get there. Okay? Now, the first thing we have to go over, which is very, very common. Please make sure you know this in and out, okay? Benign prostatic hypertrophy or hyperplasia. Now, with this, they say that this is seen in 80% of men over 60 years of age. Okay, so there's your incidence there. Etiology is quite unknown, although they do feel that sometimes this has to do with the male's hormone. So maybe the hormone is decreasing. Much like when females go into menopause, not that men go into menopause, but they also do have an altered hormone secretion that occurs. So they do believe that this has something to do with it, although they don't know the exact cause. Now, what happens here is that the prostate tissue will actually start to go into a state of hyperplasia, meaning that the prostatic cells will now increase in number. When it increases in number, it makes the whole prostate gland larger, okay? So sometimes you'll hear it as a hyperplasia in this sense, or you may hear it as, I think commonly they use hypertrophy, okay? Benign prostatic hypertrophy. Now, the other issue here is that, going back to anatomy, if the prostate gland is large, what sits right between the prostate gland? The urethra, okay? Now, if that prostate gland gets very large, what is going to happen to the urethra? It's going to start obstructing the urethra, constricting it, which means that now these patients are going to have what? Decrease in urination. Okay, so they're going to have urinary issues. Another thing that's not listed here, so urinary retention, obstruction of flow, decreased stream, all of that have to do with the urine. Okay, hesitancy, okay, difficulty getting in and out or whatever. Now, the other thing that is not listed here, and not to sound nasty, but this is actually part of, keep in mind that the prostate makes a good portion of seminal fluid. So sometimes patients may come to you and say, I'm having difficulty urinating, okay? And usually with the male, that's the first thing that they think about, if they're not having a urinary tract infection or anything like that. The other thing that the male patient may say to you is that the semen color looks different because the prostate gland actually gives the semen its white color. It actually gives it its more, let me see if I'm getting this right, the more alkaline portion of it. So it's more white in color. So they'll come to you and say that my semen is clear. That should be a trigger in your head that something's wrong with that person's prostate. What else? They can also have a decrease in seminal flow as well, because keep in mind that the urethra carries not only urine, but it also carries seminal fluid. Okay. Diagnostic tests, rectal exam, bladder scanning, which could see, okay, the actual constriction of the urethra, and any type of urodynamic testing to see if they're able to go and the flow and all that. Now, with rectal exam, I will tell you this is, believe it or not, when I was in school, they made us do rectal exams on the dummies, okay? And when we had to do these rectal exams, okay, on the models there, what happens is that when you feel a prostate, and you guys will learn how to, do testicular prostate exams. When you feel the prostate and it's a BPH, it's usually large all around. Whereas if a person has, say, a prostatic tumor or some sort of cyst, it's usually just one area, okay? So you can feel the difference between the two. Treatment here is alpha blockers or 5-alpha reductase inhibitors. And what they will do, just to let you know, they will actually release the muscles in the gland and reduce the tension. So they will release or relax the muscle and reduce the tension. Okay. So microwave therapy, needle ablation, so anything that they can do to try to shrink it, that's the goal, or to take it out. Okay. And with imaging, understand that they can see the area of the hyperplasia, so they can just go right in and, just kind of pull out or laser that particular area. Okay. So it's not that they just have to laser the whole thing. So this is what it looks like. Here's a urinary bladder. Okay, if you remember from anatomy, there's a urethra. Here is the benign prostatic hypertrophy tissue, very large around that area. Okay. So as you can see by looking at this, okay, they're showing you the prostatic urethra gets narrowed, okay, by that enlarged prostate. So therefore causing issues with urinary flow and so forth. Okay. The other thing they're showing you here with this picture, well, they're showing a lot of things in this picture. Okay. With this picture, they're showing you I'm sorry, oh yeah. Enlarged prostate, but they're showing you here how this can now turn into an influx, or excuse me, a reflux of urine, okay? Which makes sense because if you have now urine in the urinary bladder, urethra is now constricted, it's not moving forward, so where's the urine going to go? Now we're going to have a backup of urine, okay, going through the ureter and now causing an issue here in the kidneys, leading to what they call a hydroureter or hydronephritis. So you'll have extra fluid in the ureter, excuse me, in the kidney, also in the ureter, making this whole situation dilated, okay? Now obviously that's a very bad issue there with all of that going on. I believe that's more of a late stage. They usually catch it when it's down there, okay? So that's that situation. Now, prostatitis. Prostatitis, very easy, inflammation of the prostate, okay? What does this come from? Bacterial infection, okay? Now you're probably wondering, how do you get bacteria in your prostate, okay? Please keep in mind that there are ways that people can get bacteria in the prostate region, just like any orifice, okay? And a lot of this comes with, believe it or not, hygiene, okay? That's that. Still nothing to say about that. So, and we're going to talk about it again here, okay? But they show you other ways bacteria can get to the prostate. So sometimes internal, but from external, that's usually more hygiene. Okay, so they're showing you here, it can get through the bloodstream, okay? So bacteria from other sites can get through the bloodstream and then go that way to the prostate. Or from the bladder or the kidneys, okay? If they are experiencing some type of infection, it can just get to the prostate that way. Direct extension, okay, coming from bacteria spread from the rectum. So again, this is the part that I was talking about. And then also ascending from the urethra, okay? So usually when it comes from the external roots, whether the urethra or the rectum, this is usually more of a situation if that person has, say, a bacterial infection, maybe that's, well, they give you, I'm sorry, the types of bacteria. Whether it's an E. coli or whatever type of organism, okay, that's in that region, okay, and especially going into both roots of entry. So with prostatitis, excuse me, this is an itis. So patients will have fever, chill. They will also have lower back pain in that region. Keep in mind with prostatitis that the prostate will actually get a little larger. Okay, so not that it's a full BPH, but it will get larger because of the inflammation that's going on. So they will have pain with that. Frequency, urgency, dysuria, difficulty in urinating, tender, swollen prostate on the exam, okay? So you would be able to tell the difference between that from a BPH, okay? And the way to really determine the difference between that and a BPH is, what would you do? Just clinically thinking, what would you do, what type of test would you do to determine this from a BPH? Something I just said about this. You would do a culture. Okay, very good. You would do some sort of culture or testing to see if it is a bacterial infection. Okay, because this is mostly from a bacterial infection. Okay, so that's that. So diagnosis, urinalysis will have increased white blood cells and obviously the presence of that bacteria. And the culture is needed, okay, as we just talked about. In the treatment here, giving them antibiotics, they give you the type there. I'm not going to test you on the exact type of antibiotics, but just know that antibiotics are used for 4 to 6 weeks. Okay. Any anti-inflammatory agents, and they do have here alpha blockers, which are supposed to relax the contraction of the prostate muscles, prostatic massage, and sit baths. So anything that's going to relax the muscle and calm down the inflammation in that area. And then the last thing that we're going to go over is prostate cancer. Okay. Prostate cancer, quite common, unfortunately. There is a high incidence of prostate cancer. They do have the incidence here, annual deaths, new cases, and so forth. Rare, as they say, in young men, but it's definitely more prevalent in men over 50. Okay, I would definitely know that. The etiology we know is unknown, just like any other cancer. We're not sure exactly what causes this, but there are some risk factors, okay? So make sure you go over the risk factors, genetic, hormonal, dietary, which are the common risk factors that we know for all around cancers, okay, with this. Can be aggressive. The only thing to say about the prostate cancer, it does have its staging that's here. So I would just kind of highlight this and just make sure you read through all the 4 different types of staging. Okay, so there's not much to say about that. Diagnosis, rectal exam, biopsy, which we know to look at the cancerous cells. And the other thing here is looking at the serum prostate-specific antigen, which is the PSA test, okay, which you guys know. The PSA test is extremely important because this tells us that this cancer is actually the prostatic form of cancer. Please understand that this is considered to be what we call a tumor marker, okay? PSA is considered to be a tumor marker. If you remember, I think I went over, I'm not sure. Oh no, I didn't, because the new book and the old book is different with that chart. But when we went over the chapter with cancer in chapter 7, there is a chart in your book that goes over tumor markers. And keep in mind that when your body develops a cancer, that particular cancer will start to secrete a particular antigen or enzyme, and it will be detected and flow through your bloodstream, and that's how you'll know that this is the particular cancer that person has. And again, remember I talked about this with neoplasias. The beautiful thing about the body is it will secrete this from the primary cancer only. So if this person has a metastasis going somewhere else, that bone cancer won't secrete an enzyme, but just the prostate itself. Okay, so you'll know the primary cancer, so to speak. Transrectal ultrasound, where you can actually see the tumor itself. Treatment, they say watchful waiting. I would say that's in the beginning. Usually prostate cancer is treatable, from my understanding, if it's caught early enough, but as advanced as it gets, it's not a good prognosis. They can do a lot of therapies, as you know, from chemo, radiation, and surgery. Okay, with this, just like any other cancer. I think that's all I have to say about prostate. Okay. That was easy. All right, let's